We'll go ahead and get started. I don't really have a lot of content to get through today, so hopefully we'll finish early. And if you paid attention to the topic outline, today we're going to spend some time talking about sexually transmitted infections. And I'm going to focus in on the ones that are probably most common or prevalent in the United States. There's a lot of infections that get spread sexually, and we're not going to spend time talking about all of them today, but the ones that are of significance include chlamydia, gonorrhea, and then this huge uptake in syphilis that we're seeing here throughout the United States. So what I'd like to do is talk about some of the epidemiology and risk factors associated with these particular infections. How do they manifest in a patient who's been infected? acutely, and then maybe even chronically, in particular with syphilis. And then importantly, how do we treat these infections? Because you're going to find that you will treat STIs at your local retail pharmacy as well as in the ED. So we need to be familiar with what the recommendations are as they stand today. And then you also have to keep abreast of how these recommendations and guidelines evolve over the course of the next several years, because resistance is going to continue to be a problem, in particular with chlamydia and gonorrhea. What's limiting our ability to treat syphilis adequately is just the availability of the drug of choice, the penicillin. Yeah, but before we get into that, it was suggested that we talk about a couple of other common infections. This first one here, I'll pose this to you. The emergency room physician calls you in the pharmacy one evening and states that he's got a 22-year-old female with BV. He's upset because his clinical support system is currently down, not surprising, and he cannot recall the appropriate treatment for this. He's asking you what the best treatment for BV is. Now, how do you reply to that? Do you simply say, I don't know what BV is? And maybe some of you are saying that to yourself right now. My favorite, let me double check, because I always double check. And that just sounds better than saying I don't know. Although C is probably, right? Ask Dr. Lewis. Or let me double check again. So what do you know about BV, or bacterial vaginosis? I will start by saying that bacterial vaginosis is not a sexually transmitted infection. Okay, it's not a sexually transmitted infection. It's actually a state of dysbiosis that occurs in the vagina secondary to, most likely, sexual intercourse. And what we have in a patient with bacterial vaginosis is an overgrowth of specific organisms, anaerobes, right, due to pH changes in the vagina. And most commonly identified when assayed or when investigated is an organism called Gardnerella vaginalis. So that's the most common anaerobe that overgrows secondary to pH changes. These pH changes, again, they create a different environment for Gardnerella, and then it takes over. And when it takes over, you end up in a state of dysbiosis. And this dysbiosis is characterized by a volatile amine odor. So I don't know if you guys are ever in the organic chemistry lab and you got a whiff of triethylamine or diethylamine, or if you can equate that volatile amine odor to that strong fishy scent, that's really what's occurring here in this patient who's suffering from this. The patient may be asymptomatic, or again, may have this discharge. And then in more severe cases, pain, dysuria, inflammation, irritation, again, that may occur alone, but it might also suggest that there's something else going on as well. So they might have a co-infection with a separate microorganism. And again, the integrity of the endothelial layers, the epithelium, and the mucous membrane in the presence of any type of infection in the urogenital tract predisposes or increases the likelihood and the risks of subsequent STIs, including HIV. So one infection can ultimately lead to multiple infections, in particular if the exposure is there. Treatment. So if anaerobes are the cause of bacterial vaginosis and overgrowth of these anaerobes, what do you suspect is the best treatment then? You want to give Flagyl 500 BID for 7 days? Would you like to use this metronidazole gel, 1 applicator full, vaginally at bedtime for 5 days? Could we use this Cleocin cream, 1 applicator full at bedtime for 7 days? Or might we go ahead and just use Cleocin capsules, 300 milligrams BID for 7 days? So what do you suppose is the best choice? Or before we get into the next part, which is probably already on your slides and printouts, are all of these technically feasible? All of them are technically feasible. Is one better than the other? And it seems that the preferred regimen for pregnant and non-pregnant individuals ends up being metronidazole, all right, orally, BID for 7 days. That's the recommended treatment, okay? And as I suggested, Clindamycin also kills anaerobes, so it's not a wrong choice. I just don't like clindamycin for pretty much anything these days unless it's absolutely required. And the downside is that when you apply something topically, when you're using a cream, a gel, or an ointment for any indication, that local application is assuring that you're putting the drug right where it's needed. Okay, right on this rash, right on this lesion, right on this wound. Okay, same holds true for the use of creams and gels when they're used vaginally. You are inserting them right where the infection is. So the likelihood of systemic exposure is greatly reduced, number one. Number two, the drug concentration that the patient's being exposed to is far less than oral administration. Whenever you give a drug orally, systemically absorbed and distributed, increased risk of side effects. But regardless, topical administration for this infection isn't preferred, but it is equally effective. So if there's a reason why a patient couldn't take Flagyl orally, you have outlets, you have other choices that you could use to treat this infection. Okay, questions about bacterial vaginosis? You guys have probably all dispensed Flagyl or clindamycin for this and may not have even realized it, okay? I think there was an interesting article. I'm gonna have to get this article and read it in a little bit more detail. What's the one thing we always tell people when they take Flagyl? Don't drink. And where is the basis for those particular recommendations? Where's the study that actually lined up a group of college students in an infectious disease course and gave them Flagyl and then asked them to drink alcohol or drink water and then see what happens? Where is that study? So I think that the evidence out there to suggest that that interaction is a true risk is fraught on poor evidence. And I think I was looking in Lexicon. I can't remember. I'm going to have to look. But I think they're actually removing the recommendation of no alcohol when metronidazole is being used for bacterial vaginosis or maybe even this next infection, trichomoniasis. Let me look and I'll find it to you because I don't want you guys to give out wrong information, but just it's mostly so you're informed, if nothing else. Later that night, same doctor calls you. You guys did such a good job. He's calling you for some recommendations on how to treat a 24-year-old female with trich. So he's asking you to remind him, how do you treat trich? Well, what is trich? Let me double check again. Or let me ask Dr. Lewis again. So what are you going to do? What is trich? Trich, again, is trichomoniasis. And you guys have probably all dispensed medication, and particularly if you work in a retail setting, for the treatment of trichomoniasis. Okay. Trichomoniasis is caused by Trichomonas vaginalis. And this is a very, very successful and very, very common sexually transmitted infection worldwide. Right? Trich is a flagellated protozoan. Okay. And again, worldwide, it is probably the most common non-viral STI. To date, humans are actually the only known host for this particular parasitic infection, for this particular sexually transmitted infection. So you think this could be something that we could eradicate, but we don't have a vaccine. We don't give prophylactic antibiotics to prevent against this. We treat on demand when somebody presents with signs and symptoms. The downside, again, why do these sexually transmitted infections spread from person to person? A lot of these STIs that we're discussing actually are asymptomatic. So a patient doesn't even know that they have the infection, and then they go and engage in risky behavior, and that just propagates things. So the majority of the time, the patient may be asymptomatic, in particular in men who harbor and spread the infection. However, there can be an inflammatory disease that occurs in the urogenital tract as well. And then here are some signs and symptoms that are associated with trichomoniasis. Discharge, burning upon urination, pruritus, dysuria, Patient may have frequency, things that mimic and seem like a urinary tract infection, lower abdominal pain as it progresses, and then dyspareunia or painful intercourse. So treatment-wise, trichomoniasis is a flagellated protozoan. So what makes the most sense with regard to treatment options? These look similar to what we just described previously. Do we use Flagyl? Can we use the metronidazole topically? Can we use the Cleocin topically? Or can we use Cleocin orally? And again, too, the trade name Flagyl actually came from the fact that it was used initially to treat flagellated parasites, flagellated protozoans. So that's where that was the genesis of the trade name product. And for the treatment of trichomoniasis, what's actually recommended, again, much like we just described for BV, for pregnant and non-pregnant individuals with trich, 500 milligrams BID for 7 days. Okay, that is actually what you want to make sure that your female patients are getting for the treatment of this infection. Historically, this used to be treated with just a one-time 2-gram oral dose. And that was probably curative in most patients. But what has been discovered is that trichomoniasis has this reservoir sites in the urogenital tract, and certain areas of the female anatomy do not achieve good concentrations of metronidazole to actually address the presence of the parasite. So that 2-gram dose, while it gets up there concentration-wise pretty good, and has good adequate penetration into most of the sites of infection, these periurethral glands are not achieving high enough concentrations to eradicate the trichomoniasis when they hide out there. So that 2-gram dose is no longer recommended for females. However, it is still recommended for men. Okay. And speaking of men, individuals that identify as having a penis, a phallus, or a neophallus, that one-time dose of metronidazole, 2 grams, is appropriate and curative. Other options, and these are 2 drugs that, I mean, I've only seen tinidazole dispensed once in my 20 plus years of pharmacy. So I don't know if you guys will ever encounter this, but tinidazole is a nitronidazole derivative. Mechanistically, it works the same way as metronidazole. It could be used. It's an alternative. Secnidazole is a little bit newer. Again, same mechanism. I think what really calls into question on whether or not you're dispensing this is the payer, the PBMs. So you get a prescription for tinidazole or secnidazole, and you submit that, and you see not covered. You know, use this first. Use this first. So availability and cost. Is the patient going to pay out of pocket for either of those 2? Probably not. Are they equally efficacious? Yes. So you may find yourself making a phone call. Can you use metronidazole in pregnant individuals? Is metronidazole safe and effective in pregnant individuals for the treatment of trichomoniasis and bacterial vaginosis? Yes. Yes. So it's safe in pregnancy. Okay. These other 2, though, secnidazole or tinidazole, if these are being considered as alternatives to metronidazole, they are not safe to use in pregnancy. Questions or concerns about bacterial vaginosis or trichomoniasis? They're very common. You'll treat patients with those 2 conditions. All right, let's talk about chlamydia. All right, question. Chlamydia trachomatis is the most common notifiable disease in the United States. You find that to be true or false? By show of hands, how many think it's true? 1, 2, skip a whole bunch, a couple more. Who thinks it's false? All right, so actually, this ends up being true. I don't know if that number surprises you, but data that we have from 2022 suggests that there were 1.6 million reported cases. So that's a lot of chlamydia circulating around. As such, you find this next statement to be true or false? Unless you find it to be a highly transmissible infection? Pretty much, yeah, very much so. Right. Signs and symptoms of a chlamydia infection. Well, not surprisingly, most patients can actually present with no symptoms whatsoever, and it is identified during routine care. However, males, might they present with a mucoid or mucopurulent discharge? Urethritis, could that be present in both men and women with chlamydia? Irritation of the urethra? Cervicitis, could that be possible in a female patient? Could patients present with conjunctivitis that have chlamydia? So yes, all of these end up being true, okay? So those are common signs and symptoms of chlamydia. What are complications of chlamydia, in particular in a female? Untreated, this could progress and become a pelvic inflammatory disease. So as the infection spreads from the urogenital tract up into the lower abdomen, into the pelvic area, and starts to affect the ovaries and the fallopian tubes, I mean, that could all of a sudden have some fertility consequences. With that, you see pelvic pain, of course, infertility, and then in men, inflammation of the epididymis can also occur. So there's a lot of reasons all of a sudden that you want to identify and then treat these infections, in particular chlamydia. Is it possible that chlamydia could present with non-genital manifestations then? What does that suggest? Non-genital manifestations. Could you have other areas of the body that are infected with chlamydia? Absolutely. We already mentioned conjunctivitis, and that largely is a auto-inoculation phenomenon. But you could have proctitis, tonsillitis, and then pharyngitis. Right? So you have regular vaginal intercourse, you have men who have sex with men, you have anal intercourse, you have oral sex that is occurring every day throughout the United States. You get the two right people in the right room, one of them has chlamydia, any and all of this can occur. Having said that, who really should get screened for chlamydia then? So our MSM population, men who have sex with men, they're a high-risk group. So they probably need to be screened for chlamydia and other sexually transmitted infections, including HIV, definitely annually, but probably every 6 months. Pregnant women definitely need to be screened, not just for chlamydia, but for this whole torch pathogen panel at their first obstetric visit. Newly incarcerated, you show up to serve your term in jail. And weird things happen in jail. Just watch some TV once in a while. And individuals who are newly incarcerated ought to get screened for chlamydia and a variety of other infections to make sure that they don't spread infections in-house. Sexually active women less than 25 years of age, and then sexually active women greater than 25 years of age who are described from guidelines as having high-risk features. And what are those high-risk features? Entertaining a new partner or having more than one partner. This one made me laugh, partners with partners. So, and then individuals greater than 25 years of age who have a sexually transmitted infection. Right? So if you're knowingly engaging in intercourse with somebody that you know has an infection, I mean, not only are you putting yourself at increased risk for infection, you better go get tested not too long after that. And here's the source reference for those recommendations if you're interested. Okay, so how do we diagnose chlamydia? What's the best way to diagnose chlamydia? Thinking about what type of pathogen it is. It's a bacterium, okay? Is it gram-positive or gram-negative? I'm asking anybody. Okay. We made eye contact awkwardly, so I'll look the other way now. Oh, sorry. When that happens. I should just teach like this. That way we wouldn't have any of that awkwardness whatsoever. You guys could make fun of me and I wouldn't even know it. So chlamydia, how do you characterize that particular organism? I'll add a third choice. Is it atypical? Yeah, it is atypical. Right? So knowing that it's an atypical organism, you're not going to do a gram stain on it. Okay. Since we don't do a gram stain on it, what about serology? Can we do serology to detect the presence of chlamydia antibodies? Or do we do a urine test to check for the presence of chlamydia antibodies? Would that be possible? Might be possible, but what does that tell you? If you have IgG present in the serum of a patient who you have in front of you, what does that really tell you? Does that tell you that they have an active infection right now? Does it tell you that they were exposed at some point in time? Absolutely. Okay. So serology isn't necessarily the best approach to use to diagnose either. What does that leave us with? Is it a clinical diagnosis? We just diagnose it based on a clinical presentation. I would say most of the time, probably, because not everybody has quick access to nucleic acid amplification tests. All right, so NAAT or nucleic acid amplification tests are basically getting a swab of what is probably an infected site from the body, putting it in a PCR and then amplifying, looking for the presence of DNA, looking for the presence of chlamydia DNA. That's actually the preferred route, the preferred mechanism for definitively diagnosing chlamydia, since you can't do gram stain in culture. So I'd say that plus just the clinical suspicion is good. And again, too, since we have these extragenital manifestations, sometimes a swab from the throat or a rectal swab is also going to be utilized to rule out the presence of infection in those particular anatomical regions. All right, this is where the rubber meets the road. The preferred regimen for the treatment of chlamydia in a non-pregnant patient is it Rocephin 250? Is it Rocephin 500 milligrams, IM times 1, the higher dose? Do you want to give them some Zithromax, 1 gram times 1 dose? How do you feel about doxycycline 100 BID for a week? What about Amoxil TID for a week? What are your thoughts? Turn it over to the crowd. Silence. Silence. Somebody responded. Zithromax. Okay, I have a vote for Zithromax. 1 vote for Zithromax. Do I have 2? 2 votes for Zithromax. 2 votes for Zithromax. Do I have 3? Give me 3 votes for Zithromax. No, 3, no, 2, going once, twice. Okay, 3 votes for Zithromax. Do I have 4? 4 votes. 4 votes. None. Nobody? Okay, you want to vote for Zithromax. I know you do. Did I talk you into it? Dang, I'm good. I should quit this job. That's for dang sure. Okay. That's wrong, actually. Zithromax. So if Zithromax is not the preferred regimen, what might be next? Doxy. We got this whole row. Alec, are you in on this? All right, I got 4 votes already. More doxy. Do I hear even more doxy? Oh my gosh. Yes. Actually, this is correct. So today, here in 2024, the preferred treatment for chlamydia in a non-pregnant patient is doxycycline, 100 milligrams BID for 7 days. Okay? This used to be, Jacob, that used to be the preferred regimen, and it's beautiful, from a ease of use, directly observed therapy perspective, but our ability to cure most patients with Zithromax is starting to decrease more and more and more. And as such, that doxycycline regimen has risen to the top. And there's reasons for that. Would we ever consider using Rocephin? Not for this particular infection. How about this? This is curious. Amoxil 500 TID for 7 days. Why does that appear as a recommendation for pregnant patients? the treatment of chlamydia. We'll come back to that. It's very, very interesting. All right. Speaking of our pregnant patients, we know we're not using this or this. We're not going to give a pregnant patient doxycycline, are we? So what does that leave us with option-wise? What would be the preferred option? Zithromax here. This is where you want to utilize the Zithromax, okay? And if the patient is intolerant to Zithromax for whatever reason, then you might opt for the amoxil, okay? I would have to say that chlamydia's got a very, very interesting life cycle. It kind of exists in a couple different morphologies. There's these things called elementary bodies that are infectious, the infectious particle, if you will. They're not necessarily highly metabolically active, but they have the ability to spread from person to person and grab onto an epithelial cell and then make their way into an epithelial cell as an elementary body. They just abbreviated EB in the literature. Once they make their way into that epithelial cell in the ureterogenital tract, what they do is they undergo some metabolic changes. Remember, they're inside this vesicle. What do they call it? It's technically a phagolysosome, but they actually prevent the lysosome from merging. Okay, and after they're in this elementary body, actually, when they're in this vacuole, what they do is they undergo some metabolic changes from that elementary body to a reticulate body. That's the metabolically active form. That's the form that starts to replicate through binary fission. So elementary body attaches, endocytosed, exists now in this phagolysosome, undergoes a metabolic shift to these things called reticulate bodies, and then they start to divide via binary fission. And what they have identified, what researchers have identified, is the presence of a peptidoglycan ring that exists during this replication process. And they've identified at least 3 penicillin binding proteins that get expressed during this metabolically active stage in chlamydia. Okay. So then they divide into 2 separate chlamydial microorganisms, and then they go on and do it again. Again, that ring forms again and again. And this happens over and over and over. And at some point, those reticulate bodies are going to evolve back into the elementary bodies. The cell will burst, and this will lead to subsequent spread to other cells in the area of infection. So the identification of these penicillin binding proteins, the fact that radiolabeled penicillin bound to them makes one pause and say, what's going on here? Can we actually use a beta-lactam to kill these microorganisms? And in fact, you can't kill chlamydia. It's not bactericidal, but what it does do is it causes significant morphological changes during the replication process, and you get these aberrant bodies that form. So instead of looking like this binary fission dividing microorganism complex with that ring in the middle, what you get is something that looks all out of whack and all crazy looking, and that ultimately then succumbs to the immune system. Okay? So from my understanding, this is the rationale why you can use something like amoxicillin 500 milligrams 3 times a day for a week to treat a pregnant patient with chlamydia if they can't tolerate the Zithromax. Patient was diagnosed and treated for chlamydia. So she returned to the clinic for a test of cure 7 days after the completion of treatment. perform tests of cure on patients with chlamydia? Individual that we want to have come back and do quote unquote test of cure is if she's pregnant. If you have a pregnant patient, you want them to come back and do a test of cure. You don't do it after a week, you do it after about 3 or 4 weeks. So that's a test of cure. If you wait longer and put it out to about 6 months and you have that patient come back to retest them, then what you're really doing is that's a test to determine or detect reinfection. Okay, so they're different. Test of cure versus test of reinfection. 3 months later, test of reinfection. I said 6 months, I meant 3 months. I apologize. And then just a couple comments about this whole Zithromax deal. True or false? We can have extragenital manifestations of chlamydia. True. This could include rectal chlamydia. It could include throat or pharyngeal chlamydia. True. All right. We know that Zithromax historically has done a really good job of achieving a high enough concentration, well above the breakpoint, well above the MIC for the treatment of genital chlamydia. But where the data starts to get spotty is when we're talking about these extra genital manifestations. I don't think there's a lot of good data out there to suggest that Zithromax does an adequate job of curing rectal chlamydia or even pharyngeal chlamydia for that matter. Okay, and that coupled with the increasing resistance poses a problem for a lot of patients. The data has suggested that doxycycline compared to azithromycin for the treatment of genital chlamydia is about equivalent. But when you start teetering it over into rectal chlamydia and then pharyngeal chlamydia, the doxycycline is by far much better. Okay, it's just much more efficacious compared to the single dose of Zithromax. And here are some links to substantiate that. What is the liability of 7 days of 7 days of doxycycline as compared to a one-time dose of azithromycin? The data suggests it's superior, so we definitely should use it. But can you think of a situation outside of pregnancy or allergies where you would want to maybe go for that Zithromax? Compliance issues? I think that's the biggest problem with using this regimen. We don't want people to walk out of the ER or the office without knowing that they got their medicine. And that's why single doses of antibiotics with prolonged half-lives are beautiful. But at the same time, if they walk out with a prescription for doxycycline, are they going to, number one, get it filled? Are they going to take it all? Okay. So that's the liability, I think, with doxycycline. All right. All right. What questions or concerns do you have about chlamydia? You will still see Zithromax being used to treat chlamydia. I saw it a couple weeks ago. Got a 1 gram dose of chlamydia, and I can't remember how many milligrams of Vantin. I think it was 400 milligrams of Vantin. So you're going to see it. Good segue. Thank you. Thank you. On to gonorrhea, shall we? All right. Gonorrhea, sexually transmitted disease caused by the gram-positive or negative organism. It is a Diplococcus. Gonorrhea. There's another PowerPoint uploaded with these already filled in. I know my handwriting sucks, so sorry. Where does this one fall? Gonorrhea. We already said that chlamydia was number 1, right? So we can cross out A. Is it second, third, or fourth? What do you think? So it's number 2 on the list of reportable infections. And then in 2022, how many cases do you think were reported? See, I got a vote for, how did you know that? Oh, just say you knew. Don't say you guessed. That's all right. We're going to learn, aren't we? But Alec is right. There's about 648,000 plus or minus a couple hundred here or there diagnosed in 2022. So that's a lot of gonorrhea going around here in the United States. That's just the United States. Okay. So gonorrhea rates, again, too, these are increasing, not just here in the United States, but they're increasing worldwide. And I think we had an all-time low back in 2009, but then these rates have just gone like this significantly across the globe. And more importantly and more eye-openingly is the rate of resistance. Okay, so we used to use two drugs to treat gonorrhea. We used to use a beta-lactam, a cephalosporin, and then we would pair that cephalosporin with some azithromycin to double treat it. And what we've seen now is that the utility of azithromycin as a partner drug to, say, Rocephin for the treatment of gonorrhea has gone by the wayside. The resistance rates continue to escalate up, 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 and up. So as a result, we don't even really use azithromycin as the preferred initial treatment for gonorrhea. Right. Symptoms. 50% of patients with gonorrhea may have no symptoms of the infection. Do you find that to be true or false? And unfortunately, again, that's true. So no symptoms, you don't know you have it. You don't know that they have it. Let's go. Females may present with cervicitis, urethritis, dysuria, bleeding, abdominal pain, dyspareunia. So again, that abdominal pain really starts to signify a little bit more of a serious infection. It goes from uncomplicated to complicated once you start engaging in a discussion of pelvic inflammatory disease. And then the male counterpart, what's most common in men is a purulent or a mucopurulent discharge. So as it sounds, you know, they have a discharge. And you can actually identify on gram stain the gram-negative Diplococcus from the purulent discharge. We also do have non-genital manifestations of gonorrhea. Again, pharyngeal manifestations, similar to what was described for chlamydia. Ocular, again, auto-injection. How many times a day do you touch your face? How many times a day do you touch your eyes? How many times a day do you touch somewhere else? I mean, it happens. You have rectal manifestations, proctitis, a burning sensation and inflammation of that area. And then it starts to spread beyond the genital tract and infect other areas of the body, in particular the joints or valves in the heart, or worse yet, even the meninges. This all of a sudden goes from an uncomplicated infection to a complicated infection. Screening wise, again, same patient population that we described earlier. Men who have sex with men, pregnant women, newly incarcerated, and then that demographic of sexually active females. And then what is the preferred technique for the diagnosis of gonorrhea? So again, gonorrhea, it's a gram-negative Diplococcus. So you can gram stain this. Culturing is very, very difficult, by the way. It's very difficult to culture gonorrhea. And that makes then susceptibility testing equally difficult. But nonetheless, how do you diagnose it? Preferred mechanism here again is the nucleic acid amplification test, getting a swab from that mucopurulent discharge, getting a cervical swab, a pharyngeal swab, or a rectal swab, and then subjecting that to amplification can help you then identify the presence of the infection. Gram stain and culture actually is diagnostic in a man as well. So having said that, then, what is the preferred treatment for an individual with gonorrhea? Rocephin 250, Rocephin 500, Rocephin 1 gram, Zithromax 1 gram. Do we do both Rocephin and Zithromax? Do we do Rocephin and Doxy? Do you have any thoughts how you might treat gonorrhea? Which one? B? Got to vote for B. Anybody want to second that? Does somebody else have a different thought? Open to discussion.
I'll vote for F since you said there's increasing resistance.
Okay, so I've got to vote for F. All right, others. Anybody else have a different thought? So it turns out for uncomplicated gonorrhea, that could be genital, rectal, and or pharyngeal. 500 milligrams of Rocephin, IM times 1, is the preferred treatment option. Okay, it's the preferred treatment option, and it's curative in just about 95% of individuals. The MIC value for circulating gonorrhea here in the United States is still probably below the it's 0.125 microgram per ml threshold, so it's still sensitive. Is this wrong, Jacob? Increasing resistance, we overcome resistance perhaps with a higher dose. That's why the 250 dose isn't used anymore, actually. Increasing resistance as well as tissue penetration to certain areas. Right? But there's a special circumstance for the use of F, and that's right here. A patient that comes into the ER or to the office with chlamydia might very well have gonorrhea, and vice versa. Somebody that has gonorrhea may very well have chlamydia. So they partner up pretty well together, unfortunately. If a patient is noted as having gonorrhea, there's a good chance that they have chlamydia. If you can't rule out chlamydia at the time of the visit, then you empirically treat for chlamydia. And you do that with that preferred regimen, Doxy 100 BID for a week, okay? However, if you have the capacity to do the nucleic acid amplification test and it comes back negative for chlamydia, you just give that Rocephin. Rocephin is a third-generation cephalosporin that has been shown to have the highest efficacy against gonorrhea, although mutations that have been noted in various penicillin binding proteins are starting to actually reduce Rocephin or ceftriaxone efficacy. So as such, the MIC has been creeping up. And then, like I said, some of these other issues that have cropped up really have called for an increased dose. And one of those reasons has to do with the pharyngeal gonorrhea. So that 250 milligram dose of Rocephin actually did quite well for the treatment of genital gonorrhea, and it probably did an adequate job of treating rectal gonorrhea as well. But when you start to talk about the rectal site and the pharyngeal site, there's a lot of information we just don't know about drug penetration and the pharmacodynamics of Rocephin getting into the pharyngeal tissue to eradicate the infection if it's there. So as a result, we overcome this by giving twice the amount of drug, and then twice the amount of drug is supposed to force its way into that tissue to achieve a high enough concentration. And that one-time dose, what the pharmacokinetic and pharmacodynamic modeling has suggested is that that one-time dose achieves a concentration well above the MIC for at least a 40-hour window. And that results in then about a 99% cure for most patients with genital, rectal, or pharyngeal gonorrhea, or tissue penetration with the lower dose in the pharyngeal tissue. Are there individuals out there that might have a bona fide anaphylactic reaction to cephalosporins and other beta-lactams? They're out there. And you know what's interesting is they're going to show up when you're working. I guarantee it. Because it felt like it happened to me all the time. Not necessarily with gonorrhea, but with other infections. It was never a simple patient. It's always a patient with renal compromise and an allergy. So it's not how you want to start out your shift. Anyhow, what do you recommend if the patient has gonorrhea and a history of anaphylaxis to a cephalosporin? Well, A and B are just there to see if you're paying attention. So we can throw those out right away. Do we go with C or do we go with D? How do you feel about giving an intramuscular injection of gentamicin at that dose and pairing that with azithromycin? Or you want to give this stuff called bicillin LA plus azithromycin. What is bicillin LA? Anybody have any familiarity with that? Have you heard of that? Penicillin G benzathine. You ever seen it? You ever seen the syringe? Yeah, it looks like a shotgun shell. It's this huge, thick syringe with all of this white suspension in it. And I think it's got a needle like the size of this. I mean, no, I'm just kidding. It's not that big, but they don't know that. I'm sure it feels like it though when it's going in. Nonetheless, it's penicillin. So if they have a penicillin allergy or an anaphylactic reaction to the cephalosporin, I think you're going to err on the side of safety and not recommend D. So when you look at the guidelines, C is actually what's recommended for treating gonorrhea in the presence of an allergy. One-time dose, again. And then what about pregnancy? You have a pregnant patient with gonorrhea. What might we recommend here? Pregnant patient with no allergies, recently infected with gonorrhea. What do I give her? Any thoughts? Okay, I like it. Rosefin, safe to use in pregnancy. 500 milligrams IM times 1. How about this bullet point down here then? If we can't rule out chlamydia because our chlamydia nucleic acid amplification test is down right now and out for servicing, what do we do here? We will add blank to cover for chlamydia if we can't rule it out in our pregnant patient. Azithromycin. Because we can't use doxy. Good. All right. Patient was diagnosed and treated for uncomplicated urethral gonorrhea. He should return to the clinic for a test of cure in 7 to 14 days after completion of the treatment. Do you find that to be true or false? False. Good. When do people come back for test of cure with regard to gonorrhea? All right. Pharyngeal gonorrhea. Again, too, we're still learning a lot about how to treat pharyngeal gonorrhea. We give that 500 milligram IM times 1 dose, and we can have them come back probably about 2 weeks later, do a swab, and make sure that it's no longer present. Make sure that we eradicated the microorganism. Okay, and until we learn more about the reliability and the reproducibility of that regimen, probably going to continue along that same track. If that patient returns to the clinic and they have, again, they're having signs and symptoms of the infection not resolving, again, too, that's going to be for an indication for a test of cure. And then 3 months later, again, we do a test for reinfection. So one sexually transmitted infection sort of predicts subsequent STIs. So I want to try and get ahead of things and prevent it from happening. All right. Just have syphilis left. It's 9:50. We can take a break and come back in 10 and finish, or I can just plow through your call. Thank you. Take a break. See you in 10.
I think that's my new key to like.
Yeah, I know.
Dude, I'll watch this. Even if I stay here, oh my goodness. Yeah, like I said. I see you stay. Probably. Oh, wait.
All right, so we only have a little bit more to go, so let's go ahead and finish this up. Before I start with syphilis, are there questions or concerns about chlamydia or gonorrhea? Or BV or trick for that matter? I think really what I want you to know is just make sure you can articulate what the preferred treatments are for an individual, both a pregnant and non-pregnant individual for any of these STIs, okay? Because I think that's what you're really going to need to know and be expected to suggest when you're out there. All right, the great pox or the great imitator or syphilis as it's referred to. Syphilis, what's it caused by? Again, to Treponema pallidum or pallidum is the spirochete that is responsible for causing syphilis. And again, too, when you hear spirochete, I mean, you should be thinking of this corkscrew-like organism that literally uses that type of motility to adhere and then invade into epithelial cells. And when you consider how syphilis is spread or could be spread, it's a sexually transmitted infection, so that is obvious. But there are reports of syphilis being transmitted via blood products. There is certainly congenital syphilis, so mother to child. Bites, I mean, can you get syphilis from a bite? Does that sound reasonable? I guess it depends on what you're biting and where you're biting. So any exposure to a lesion which is fraught with the spirochete can lead to then subsequent transmission. You do not need to have engaging in any type of sexual act to technically be infected with syphilis. In fact, I think I was listening to a podcast and the infectious disease physician was talking about how one of his residents touched a patient, who had syphilis and actually acquired it from just interacting with a chancre that was on his leg, I think. So be careful. How many cases reported in 2022? How prevalent is syphilis? So it's not in the millions, and it's not over 500,000. But where do you think syphilis falls on this spectrum of STI reporting? You think C? I got to vote for C, plus or minus a couple thousand. What do you think? You think C is a reasonable number? Would it surprise you if it was C? Would you have expected it to be more or less? More, yeah. So it's 207,000 cases roughly of all syphilis in the United States in 2022. And again, too, it's just scary because it just keeps going up and up and up. So incidence of syphilis continues to escalate. And even scarier is the rate of congenital syphilis. So in 2022, there was almost 4,000 cases of congenital syphilis reported. And syphilis occurs in various stages, and they're shown here on the screen. And you can see the stage on the left here. So we have primary, secondary, tertiary. We have something called latent syphilis, early latent, and then late latent syphilis. And then we have something referred to as neurosyphilis. So if you kind of go through this chart with me, primary infection, that's the first time a patient actually is encountering syphilis. They get infected secondary to an exposure. It takes about a week or two for everything to start settling in and develop. And at the site of contact, usually what is developing is something called a chancre. And a chancre is sort of an area on the skin with a raised border, and then sort of a divot in the skin, and then another raised border, and then the rest of the skin. And inside this lesion, inside this chancre, if you will, is where all of the spirochetes are localized, okay? And that ulcer can develop in about a week, and it can last anywhere from 1 to 6 weeks. 6 weeks would be a protracted time to have that type of lesion. And during this time, if things aren't addressed, it starts to penetrate into the deeper tissue and start to spread throughout the body. So that ulcer or chancre is present, and then with a primary infection, you can see local lymphadenopathy. So the lymph nodes will get inflamed as well as a result of the immune response. Secondary syphilis, again, too, this is a little bit further along in the course of the infection. So rashes, skin rashes in particular, as a result of vasculitis, occur from capillary destruction, and it can happen on the palms of the hands and the soles of the feet. So that's common in secondary syphilis. You can have a variety of mucocutaneous lesions, and again, more lymphadenopathy. I think actually alopecia has been reported in secondary syphilis, so people start to lose chunks of hair. And then tertiary syphilis. So tertiary syphilis is what you get when you have no idea what's going on, or you're in a resource stricken environment. You have no care available to you. And the tertiary infections extends well beyond just the local cutaneous manifestations, the lymphadenopathy. What you really start to see is cardiovascular involvement. The heart can get affected. The large vessels can become affected. The central nervous system can become affected. The spinal column can become affected. And all of this really stems from the microorganism's ability to invade and adhere to capillary blood flow in any and all of these areas, leading to then a profound immune response and destruction of the blood flow to those areas. So the cardiac involvement, okay, you can have cardiac compromise. You can have endarditis, where the aorta actually starts to get affected due to compromised blood supply to the aorta itself through capillary blood flow. Cabus dorsalis is a condition where you start to see destruction of the posterior spinal column secondary to capillary blood flow compromise and immune response. And then you can have what's referred to as gummatous lesions, or a gumma. And a gumma is, it's a granuloma disease. A granuloma. When I say granuloma, does that resonate with you guys? Are you familiar with what a granuloma is? Have you heard that term before? Have you ever heard that?
Only on commercials.
Only on a commercial. That's right. And we stayed at a Holiday Inn Express last night, so we are good to go. So at a site of infection, you may have a local inflammatory response. And the body's response to that infection, depending on what the organism is and what cells are involved, could lead to the recruitment of a variety of different immune cells, in particular lymphocytes. As lymphocytes start to aggregate around that site of infection, they'll call out for other cells to come in and sort of wall things off. So you may have B lymphocytes, you may have T lymphocytes, you may have neutrophils, all walling off and forming, for lack of a better word, a ball around this infected area. And then after that, fibroblasts will start to come in and add to the strength of this walling effect. So what you end up with is something called a granuloma at the site of infection. It's a thick, heavy cellular mass intended to wall off an area of infection. You see it a lot with tuberculosis. People with granulomas in their lungs, and the first thing you think of is tuberculosis. Okay. With syphilis, what you can see is this gumma, or this granuloma, occurring anywhere throughout the body. This could occur in the heart. This could occur in the brain, or any other tissues for that matter. Okay. And what's scary is that the tissue that has been encapsulated by this granuloma is going to be cut off from any and all nutrients and oxygen. So it becomes necrotic over time. So gummatous lesions are pretty common at this stage of the infection. With regard to latent infection, an individual can actually have syphilis and not even know it, or not have symptoms of having the infection, but you can identify them through serology, just by doing blood tests. Early latent disease means that the patient has had a positive test for syphilis, and they probably acquired the infection within the previous year. Latent disease is beyond a year. Okay, again, you identify these folks with serology, but they acquired the infection more than a year ago. They lack clinical manifestations, so they don't have outward signs of having syphilis, and they could all the while be spreading syphilis as well. And again, we detect these folks with the serology on routine care for that matter. And then neurosyphilis. So neurosyphilis is typically seen in more of a later stage of infection, but technically it can occur at any stage. It could occur with primary if it's not addressed, or if it's a very, very nasty infection. You could see it with secondary or tertiary disease. And as it suggests, the spirochete has made its way into the CNS, and it's now causing a lot of inflammation and damage to various aspects of the brain. The part of the brain that is being affected is how that patient's going to present symptom-wise. All right, so who should get screened? Again, too, we've seen this before. So pretty much all of those individuals. And neonatal screening as well. That first visit, again, that pregnant patient is going to get tested for pretty much everything. And then high-risk pregnant women, they're going to get screened at 28 weeks and probably at delivery as well, because that then informs the medical team and whether or not they need to do anything in addition to routine care. Men who have sex with men, again, annual screen or more often. In particular, if they have multiple partners, if they are HIV positive, men who have sex with men need to be frequently screened for not just syphilis, but all sexually transmitted infections. From a testing and screening perspective, how do you test for syphilis? And there's a variety of different ways that you could detect syphilis in a patient, but I think what's really the gold standards and what's most often used is going to be what we refer to as a non-treponemal test and then a treponemal test. The non-treponemal tests are abbreviated VDRL or RPR. These are the acronyms that you'll hear referred to in talks or in the literature if you read it. Venereal disease research lab test or the rapid plasma reagin test. These are non-specific tests. They are non-treponemal tests that look for a particular antibody formed in the body that typically crops up after a syphilis infection. There's something called an anti-cardiolipin antibody that gets released secondary to syphilis infection. And when we do a non-treponemal test, the test is actually looking for the presence of that antibody. The problem is it's not very, very specific for syphilis. There's other conditions that people can end up with that cause the release of an anti-cardiolipin antibody, but it does put somebody on the map, and it comes back positive. What that can do is trigger or lead to a reflexive second test. And that second test may very well be something a lot more specific, a treponemal test. These spirochetes have a variety of different antigens. They make several antigens that are unique to syphilis. And some of these tests that are made mention here in the ELISA or this agglutination assay or even the fluorescence antibody itself, they all look for different antigens. So you have a lot more specificity with the treponemal test. Dark field microscopy, not very common, not done very often. It's actually not as easy as it seems. That's a beautiful picture of dark field microscopy showing the spirochete against the dark background, but I doubt most offices and labs actually use this anymore. But it's just another mechanism. There is no shortage of false positives, though. So that's why it's good that we have alternate tests to confirm or refute the diagnosis of syphilis. And as such, we typically need 2 tests to confirm, a presumptive diagnosis. The initial test, there's variability. I think it kind of depends on the prescriber or the physician or the caretaker, and then what that office or lab might have available to them. If the first test comes back positive, you reflex that and do a second test. If they're both positive, that's pretty much definitive then for the diagnosis of syphilis. If the first test comes back negative and the patient doesn't have any risk factors or clinical signs of a syphilis infection, then you kind of just let it go there, okay? I did post on the Canvas a sort of an algorithm from Up to Date on testing. So that's on Canvas. Here's some paper copies if you want to grab one after the fact. You're not obligated to do so. But again, to initial screening, if it's the initial screen is a treponemal test and it's reactive, meaning positive, does the patient have a history of syphilis? That's an important question to ask because it still might be remnants from a prior infection. If there's no history of syphilis, then you go on to do the second test, the non-treponemal test. And if that comes back positive, that's your diagnosis of having syphilis and you treat accordingly. Okay. But you can look through this if you want. I think it's important to just be aware of these two mechanisms to test, okay? These two are very easy to do. They're basically just on a card for that matter. These are a little bit more sophisticated. All right, so we had a patient present who had a reactive VDRL test, and then that was subsequently confirmed with a more specific treponemal test. As such, we can say that this patient has syphilis. Those two tests, coupled with a lesion on his penis that looks like a chancre and a history of unprotected sex, solidify the diagnosis. So having this diagnosis then of primary syphilis due to the presence of a chancre, what might be the best approach to treating this patient? Can we use Rocephin? 1 gram times 1? Do we use Bicillin LA 1.2 million units or 2.4 million units IM times 1? We give Pen-G 4 million units Q4 times 7 days. Or what about doxycycline in this scenario? What is the preferred initial treatment for syphilis in a patient described on the screen with no known drug allergies? Any thoughts? Yeah, penicillin. Which one? D? You want to go with D? I got to vote for D. Anybody want to second that? Or offer an alternative? Or who doesn't know? Is this a tough one? Thoughts? Anybody? Anybody? Jacob, just guess. I don't care. C. Oh, that's a great guess. Man. All right. Your answer of penicillin is correct if we're dealing with an individual who has neurosyphilis. Okay, that prolonged IV infusion is what's used for neurosyphilis. So we're not there yet. Okay. Jacob said C, Bicillin LA 2.4 million units IM times 1. That is the preferred regimen for primary syphilis. And keep note, there's two different doses or strengths of Bicillin LA, the 1.2 million unit and then the 2.4 million unit. If you have both of these in your refrigerator in your pharmacy at the hospital, the 1.2 million unit dose is probably indicated for Group A strep carriers, individuals that get a lot of strep throat that are spreading it around to everybody. That's typically what they get. We use the higher dose IM times 1 for primary syphilis. Rocephin 1 gram IM, ironically, is an alternative treatment now for syphilis, in particular in the face of decreasing supply of Bicillin LA, as is doxycycline. So there's alternatives out there to Bicillin, which is important because having a hard time manufacturing it and getting it. So primary and secondary syphilis, The drug of choice is bicillin LA or penicillin G benzathine, IM times 1. And this is convenient because you can see the drug being administered to the patient. You know that they received all the treatment that is needed, and then they walk away, well, or hobble away, depending on how they tolerate it. Okay, and that typically is curative. Bicillin LA, it's a long-acting penicillin suspension. It's a thick mass of penicillin. Can't remember the exact volume, but I think it approaches 5 or 6 mLs. I'm not really sure. I can't remember. And it's given intramuscularly in sort of a weird administration technique. When we think of IM injections like you guys do for some vaccines, you just go straight into the muscle, okay? But there's something called a Z-track IM injection, and I don't know if you've ever heard of that, but what happens is that, Alec, come here. You can just stand right there, right? So if I'm gonna give Alec an IM injection, and I'm gonna try and use this Z-track technique. I'm not doing it with the deltoid. I'm probably gonna do it in a different muscle that's got a little bit more mass to it. But what I'm gonna do is I'm gonna insert the needle, all right, part way in, and then I'm gonna push on his tissue and then go into the muscle. Oh, sorry, it's okay. And then I'm gonna spend the next 10 minutes pushing this massive suspension in. And then as I remove the needle, where the depot injection occurred, kind of slides back over and traps the suspension. Sir, yeah. You want a Band-Aid or a sucker? Sucker, please. Dum-dum? What's your favorite flavor?
Blue raspberry.
Blue raspberry.
Yeah.
I always like the root beer ones personally.
Yeah, I did come to mind. Yeah.
Or root beer.
But then the cotton candy is also blue, and that's disappointing.
Oh, you got tricked.
Yeah, a lot.
Poor guy. Sorry. Rough childhood. It's terrible. That Z-track injection is what's used for bicillin administration. So just kind of locks it in a little bit better. It's a little bit different technique. So that's for primary and secondary syphilis. And keep in mind, I think it's on the next slide, the syphilis, treponema doesn't replicate at the pace of, say, E. coli. So it is a little bit slower replicating molecule. So we want a prolonged exposure drug-wise to the microorganism so it has plenty of time to kill it as it tries to replicate. Early latent syphilis, again, too, just the one-time dose. As you get into the more advanced infections, tertiary syphilis, latent infection, these are going to require a couple injections. So a weekly injection for 3 straight weeks of that 2.4 million units. That's what's used for tertiary and then latent infection. Okay, so you get 1 IM injection today, you get another one next week, and then another one the week after that. And that's typically curative. Treponema has retained a high degree of sensitivity to penicillin over the years. So we're fortunate in that regard. Just can't get the drug. And then Olivia, you mentioned that penicillin infusion. So neurosyphilis is treated with IV penicillin G, and it's a relatively high dose, and you probably are going to do it over a continuous infusion. So it can be a protracted duration as well, 10 to 14 days. The Institute for Safe Medical Practices, ISMP, has reported in the past the inappropriate administration of bicillin LA instead of giving it IM. Unfortunately, there's been some cases of it being administered intravenously, and that has not ended well for certain patients. So a couple of them had developed respiratory arrest, and then there's been some sentinel events as well where patients have died secondary to IV administration of bicillin LA. So again, IM only on this. It sticks around for a while, about 4 weeks. Secondary to the slow release from that depot site. And again, too, it's the prolonged exposure is what's important. Okay. When we have a penicillin allergic patient, again, too, if we can use penicillin, we really want to use penicillin in that patient to treat the infection. And what has been attempted in the past is a desensitization of the patient to the penicillin. So you start to introduce very, very low doses, small amounts of penicillin, and then you gradually ramp it up such that you have this controlled hypersensitivity reaction whereby you're depleting the patient's ability to react to the presence of the drug. So you're exhausting the immune system from an IgE perspective in order to administer them the penicillin to treat the syphilis. It takes a while. It takes quite a while. And then here's an example of a protocol from the MMWR back in 2015. And again, too, this is an oral desensitization. So it's possible. It's possible. But this is extremely time consuming, and it's quite a burden, not only on the patient, because they have to stick around on the unit or in the ER for however long. Plus, you have to have dedicated nursing for this, because you're not going to walk away after you give the patient a dose of penicillin that's known to have a severe reaction to it. Alternatives, I think this is what I would opt for and recommend just to get them out of here. If they're a non-pregnant patient, again, doxycycline could be used, 100 milligrams BID for 14 days. That has been tried and proven to be effective for primary or secondary. For latent disease, we use the same regimen. We just prolong it by another 2 weeks. So you give up to almost a month of doxycycline for latent infection. And then depending on where you look and what you referred to, you'll also start to see Rocephin being recognized as a therapeutic option for syphilis for both primary, secondary, and tertiary disease. Just the dose and the duration is going to vary. Okay. And then follow up. So 6 and 12 months after treatment, we're actually going to take a look at patients this time. We want to make sure that they were cured and then that they're not reinfected. Oh my gosh, and that's it. All right. That's all I have for today. All right. Questions or concerns? Yes, sir.
So for treatment of neurosyphilis, you mentioned how box 1 against IgEs. So neurosyphilis with that Q4-hour infection, right? So it's just primary,
I see.
secondary.